Start with Senate File 1402. Madam Chair, to your bill.
Thank you very much, Madam Chair. And Chair Mann, again, committee members, I appreciate being able to present Senate File 1402 today, which is foundational to continuing to build the healthcare system necessary to meet the needs of Minnesotans, specifically Minnesota children who have been at the forefront of a mental health crisis that must be addressed. Before going further, I do have an A1 amendment that is in your packet that I'd like to move.
Senator Wiklund moves the A1 author's amendment. All those in favor signify by saying aye.
Aye.
All those opposed? The A1 is adopted. Senator Wiklund.
Madam Chair, this amendment, it does add the financing mechanism for the bill, and it adds a fiscally responsible and innovative funding solution that relies on a health plan assessment, and I will talk more about that later in my presentation. Medical assistance, or MA, is critical for healthcare coverage in Minnesota. Nearly a quarter of all Minnesotans from every corner of the state rely on MA for their health care. This includes over 40% of babies born in Minnesota. It also pays for the majority of children's mental health services. Reimbursement rates to providers who serve these communities have fallen woefully behind the cost of delivering care. This has led to a crisis of children boarding in emergency rooms, detention facilities, and with counties, and a staffing emergency in outpatient care across the state. In 2024, DHS released their outpatient rate study, which was discussed in this committee last year. After over 2 years of work by DHS and stakeholders, it showed what we've known for some time. MA reimbursement rates are extremely low compared to the cost of providing care. My bill builds on the steps we've collectively taken over the past few years and implements recommendations in that rate study. This includes ensuring reimbursement rates for mental health and physician and professional services that have an equivalent Medicare payment will be paid at least 100% of the Medicare fee schedule. And it increases the community-based children's and adult mental health rates and behavioral health home rates to the DHS study calculation, as these rates do not have an equivalent in Medicare. In addition to implementing these study recommendations, my bill also ensures master's level providers are reimbursed the same amount for delivering the same services as other clinicians, and increases funding for hospital inpatient mental health services delivered to fee-for-service Medicaid enrollees. Implementation of the bill occurs over a 3-year period. Because we have left our rates unchanged for so long, these increases come with a significant cost, and we're all well aware of our future budget projections. The good news is we have an opportunity to increase these rates in a fiscally responsible way, relying on our health plans to partner with us to accomplish our shared goals. As amended, my bill uses a health plan assessment to leverage federal matching funds. And by using a federally allowed Medicaid funding mechanism, our MCO partners get back 99% of their assessment through higher capitation rates. This assessment is determined on a per enrollee basis and applies to all health plan companies in Minnesota. There are also different tiers and different assessment rates. All of this is designed to minimize the impact on health plans. For example, the assessment rate for the first 60,000 enrollees is 0. This protects small plans. And the assessment is capped at 350,000 enrollees to limit the impact on very large plans. The assessment rate also differs for medical assistance enrollees and commercial enrollees to maximize federal matching funds and minimize the net costs to the plans. These types of assessments have become an integral financing source for Medicaid nationwide and have been adopted by both blue and red states. Compared to other states, Minnesota has not done enough to access federal funds to support medical assistance, and this proposal gives us the opportunity to change that. Members, you have a large number of letters in your packet from hospitals, community mental health providers, physicians, and diverse community partners that illustrate the magnitude of the problem we are trying to solve and its impact on our community. We know that our system has reached a breaking point. Too many children and families are waiting weeks, months, or in some cases years to access the care they need. We are continuing to see more and more children with mental health challenges boarding in a hospital, in juvenile detention facilities, or with the county because families have lacked access to early intervention and intensive community-based care. Meanwhile, more mental health providers are shrinking or closing services because they cannot hire and retain staff, and more physicians are unable to serve those most in need because the cost of providing care has increased while reimbursement rates have remained flat. We can fix this by increasing reimbursement rates while simplifying payment structures and increasing transparency. As the bill moves forward in the legislative process, I will continue to take your feedback, and I'm looking forward to your questions today, and we can continue to make changes to the bill as necessary. For today, we would like to have this bill move on to the tax committee that's required, and then we would have it return to the HHS committee for further discussion and any changes we would make. At this time, I do have 3 testifiers, and they will be able to speak to the impact of the bill, and we can go to that now.
Thank you, Madam Chair. Dr. Katie Smentek, followed by Jessica Brisbois, and I'm sorry if I mispronounce any of your names. If you introduce yourself and proceed.
Thank you, Madam Chair and members. My name is Dr. Katie Smentek, and I'm testifying in support of Senate File 1402 on behalf of the Minnesota Medical Association and the Minnesota chapter of the American Academy of Pediatrics, of which I have the honor of serving as president. I'm a general pediatrician from Mankato, where I was born and raised, and where I've worked for the last 18 years. I see patients every day who rely on medical assistance for their health care. The increased reimbursement rates proposed in this bill will improve access to care and advance health equity in all of Minnesota's patients, in every corner of the state. In addition, it will help clinics throughout the state, like mine, stay in business and avoid having to merge with a larger system or just close. Clinics like mine in rural Minnesota are just as crucial to our citizens as their health insurance. Focusing first on access. As you know, the number of Minnesotans on MA has grown substantially over the last few years. As you heard today, about 1 in 4 Minnesotans are covered by MA, and more than 40% of babies born in Minnesota are covered by MA. Unfortunately, there's not been an across-the-board increase in MA rates in decades. Currently, MA reimbursement is at about 60 to 70% of Medicare and only about 30% of what commercial insurers pay. These rates have fallen too far behind. And when rates can't keep up, services are cut, communities are left without care, and patients like mine suffer as a result. Increased rates will also advance health equity. Currently, Minnesotans on MA are disproportionately in rural and traditionally underserved areas. You have information in your packet pointing out which Minnesota counties have higher rates of patients on MA. They're oftentimes in greater Minnesota, communities like mine and the surrounding Mankato area. Increasing these rates will help ensure that those in these regions, my neighbors and their kids, are not left behind. Physicians remain committed to serving Minnesotans on MA. The program is critical to ensuring access to care for all Minnesotans. However, the failure to update reimbursements rates is forcing difficult business decisions for many services we now provide. Without these changes, we will lose more rural healthcare providers, making healthcare even harder to access. It's time to update MA payments to at least the Medicare level. Thank you for your time today. I'm happy to help answer any questions that you might have on this critical issue.
Thank you very much. Ms. Brisbois?
Thank you, Chairman and committee members. My name is Jessica Brisbois, and I am a licensed clinical social worker and the manager of acute mental health services at Children's Minnesota. I appreciate you having me here again to discuss what must be done to address the mental health needs of Minnesota kids. The crisis kids and families are facing continues to grow more critical, and solutions are desperately needed. There is a lack of mental health services in our state, and children are waiting for months to access care, often utilizing the emergency department as a last resort. In 2024, kids boarded at Children's Minnesota more than 1,200 times, a substantial increase from the year prior. This increase reflects the consistent trends we've seen each year since 2022. 77% of the patients we see boarding in our hospital and almost half of the patients served by our mental health programs rely on Medicaid, which is why increasing the Medicaid rates is vital to addressing the challenges providers are facing. The parents and guardians of these children have often recognized their child's need for support, but have run into barriers accessing outpatient services, including long wait lists. While waiting, their child's mental health gets worse, which is what brings them to the emergency department. The last time I testified before you, I expressed my concern regarding the lack of access to community-based services. The problem has continued to grow. We continue to see the capacity of mental health providers shrinking because of the inadequate reimbursement rates. In order to remain safe and successful outside of the hospital, children need outpatient mental health services. Currently, we cannot always guarantee access to these services, even for patients that are discharging from the hospital after a serious mental health crisis. This leads to more families returning to us after not being able to access appropriate care. These families are defeated and exhausted because the system continues to fail them. Across all of our mental health services, we are reimbursed for less than half of all of our costs, and as costs continue to rise, that level of reimbursement is getting worse. The current rates are unsustainable. On average, we operate these vital services at a loss, severely limiting our ability to recruit and retain the staff needed to meet the growing needs of our patients and their families. This contributes to long wait lists and is why most of our outpatient services are only available to current Children's Minnesota patients. One of the biggest impacts we can have on the mental health crisis is investing in outpatient care. That investment would decrease pressure on the rest of the system, including emergency departments, inpatient units, and other more acute services. Most importantly, it would give children and families a better chance of addressing their mental health needs. We all want to build a system where kids and families are never in crisis. We all want to see children be able to get the help they need when they need it. Foundational to doing that is making sure Medicaid reimbursement rates are adequate. We will not see meaningful change unless we take this step. Thank you, Senator Wiklund, for your leadership on this bill, and thank you, committee members, for your time.
Thank you. Ms. Brown, introduce yourself and proceed.
My name is Shannon Brown. Madam Chair, members of the committee, thank you for the opportunity to testify in support of Senate File 1402. As I said, my name is Shannon Brown, and I am the CEO of Fernbrook Family Center. Fernbrook provides mental health services to children and families across 9 counties in southeast Minnesota. My testimony today is on behalf of mental health providers and communities served statewide. This committee has heard countless testimonies outlining our mental health crisis, its painful impacts, and the new Medicaid rate structure required to resolve the crisis. Senate File 1402 begins the process of rebuilding a sustainable rate system which will increase capacity to serve children, families, and all Minnesotans. Timing for this proposal is critical. As mental health needs are growing, service providers are losing capacity faster than we are creating it. The service closures and shrinkage survey summary in your packet indicates that within just this past year, 66% of providers lost service capacity, 38% have closed services altogether, and 22% are considering closing additional services. We can't afford to lose additional capacity to meet the growing mental health needs of Minnesotans. A loss of capacity means more weeks of waiting for mental health care, needing to drive further to secure care, and an escalation of this preventable crisis. Minnesotans are struggling with their mental health. We receive 15-plus calls per day from clients or caregivers who are in acute crisis. Their child is in the hospital because they have attempted suicide. Their child is refusing to go to school and are now truant. They've been kicked out of all daycares in town due to aggression towards other kids. The caregiver has now lost their job because they have missed so much work trying to take their child to these appointments. We're rarely able to offer services in a timely manner to these clients due to waiting lists. Often families have already been told by several other providers they're not even taking referrals. These crises are directly linked to reimbursement rates that do not cover the cost of providing services. The level of training and education required to deliver mental health services does not match the pay we can offer. Our professionals are burnt out and are leaving the field, which is further decreasing capacity. One incredibly meaningful and cost-effective service that has seen dramatic shrinkage is in-home mental health care. These services reduce barriers and allow us to serve our most vulnerable clients. Many in-home clients are single parents with no transportation. They don't have childcare and are unable to leave their home due to severe anxiety or depression. By sending skills workers and therapists to the home, we can provide critical services and can prevent additional system involvement, including preventing truancy, preventing further hospitalization, and preventing child protection involvement. In-home services are some of the scarcest services and are at risk of being eliminated altogether because rates simply do not begin to cover the cost of providing these services. We must, and with Senate File 1402, we can build a path that creates sustainable mental health systems that continue to make a difference in the lives of Minnesotans for generations to come. Thank you for your leadership and support.
Thank you. Next up, we have Dan Andreessen, followed by Dr. Stephen Girardeau.
Madam Chair, members of the committee, Dan Andreessen with the Minnesota Council of Health Plans. We represent Minnesota's nonprofit insurers, which includes Blue Cross Blue Shield of Minnesota, Health Partners, Medica, Sanford Health Plan, and UCare. The council shares concerns over the low MA reimbursement levels and how this impacts providers and access to care for patients. The underlying bill is probably something that we would be supportive of, but we have several concerns about the funding approach that was just added to the bill. Just to be clear, that our read of this bill is that this assessment mainly falls on nonprofit insurers. Every MCO in the Medicaid market right now are nonprofit, and 99% of the fully insured market are nonprofit plans. Under the current design, a portion of this assessment does fall on the commercial insurance market, and we're concerned about the impacts of this in terms of higher premiums. It can look at, when you look at sometimes the proposals, it may look like it may be a minor impact to consumers. However, there can be a cumulative impact depending on what else is getting enacted at once. There's been many proposals this session to include new assessments and taxes and mandates that are all going to increase premiums in this market. For example, last session, the legislature enacted 13 new coverage mandates that started at the beginning of this year. This added around 5% to premiums in this market, which equates to around 15 to 25%. Or $15 to $25 per member per month. We also are concerned that we've missed an opportunity to lower commercial rates in this bill. Despite that we're lowering government rates, the proposal is not contemplating to lower commercial rates. As you've heard, there's concerns about the Medicaid, Medicare rates being too low, being lower than the cost of care. And as a result, we see commercial rates being 3 to 4 times higher to offset that loss. Under this proposal, we would hope to see that if we're increasing the MA rates, we would then see a commensurate decrease of commercial rates. But this language is not in this bill, and we would request adding something like this as it moves along. I think we also need to be mindful of using the California model. There were some concerns expressed from CMS that when California went this route, that they were violating the spirit of the regulations, and we're going to update their metrics for doing so. And mainly bring this up as a caution that if we're going down this route, we don't want to be put in a situation where a program is approved, it gets changed, and then there's a huge hole in the Medicaid budget. Again, the council shares the concerns, and I think there are other ways that the state can accomplish raising these rates. Health plans and providers are already taxed through a variety of means that go into the Healthcare Access Fund and General Fund. For example, the provider tax brings in around or over $800 million annually. Any portion of these taxes could be used to set up a direct payment program, which other states have used to draw down federal dollars, which would not impact the commercial market. So we'd recommend the legislature can explore this option rather than creating a whole new tax. Thank you.
Thank you. Dr. Girardeau.
My name is Dr. Stephen Girardeau. I represent the Minnesota Psychological Association. I'm here on the for the benefit of doctoral level psychologists. And the part of the bill that we object to, we support everything else in the bill, but it is the false equivalency of master's level clinicians and doctoral level clinicians that's being proposed. I was a licensed psychologist at the master's level, and I went back and got my doctorate on purpose because I knew that I would know more and be able to do more and work in more complex cases. And to say that that it is the same service is to basically say that the services of a physician's assistant or a nurse practitioner is the same as a medical doctor. The amount of training and the breadth of training that doctoral level psychologists receive is so much greater than a master's level. It takes an additional 2 years, and there's additional training beyond that. And we are literally the profession that develops all of mental health interventions. Pretty much every significant mental health intervention that there is were developed by doctoral level psychologists through the science of psychology, not the application of counseling. And so to say that they're the same is a false equivalency, and to pay them the same is literally going to drive the profession of doctoral level psychology into the dust. There's information that we've provided to you about what the projections are for psychologists moving forward. And I'm not just talking about taking care of psychologists because we're nice people. We're a necessary part of the mental health care provider services. And it isn't that psychologists should be the only providers for mental health services. We literally believe in the concept of working at the top of your license, but if you don't have somebody at that top license of a doctoral level psychologist, you're going to miss things. I have a friend who had a mother-in-law who was being treated by a master's level clinician for 9 years. And after 9 years, they were referred to a doctoral level psychologist. And an undiagnosed dementia was present, and a number of other mental health disorders were present that weren't being diagnosed because they weren't trained to look for neurological issues or being able to assess those neurological differences. So if we move into a policy of paying the same for doctoral level clinicians as master's level clinicians, you literally will be paying, you'll literally be planning for the loss of doctoral level clinicians. Thank you very much for your time and attention.
Thank you, Doctor. Bentley Graves, followed by Lou Zeidner.
Thank you, Madam Chair and members. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. We are the state's largest business trade association. We represent more than 6,000 employers in every corner of the state, every size of business, and in every industry. I think, as all of you know, health insurance is an incredibly important benefit in this increasingly competitive labor market. It allows employers to attract and retain talent and helps ensure their employees stay healthy and productive at work. But healthcare affordability for employers and their employees is not getting easier. Roughly 3/4 of our members who currently offer health insurance tell us they'll be forced to make significant changes to their offerings, including reductions in coverage and dropping coverage altogether if costs continue to increase at their current rate. Some have already had to make those hard decisions. 1 in 5 chamber members who don't currently offer health insurance tell us it's because prohibitive cost increases force them to drop the coverage that they had. I share these statistics because the legislature does play a role in healthcare costs. Among the primary ways the legislature directly impacts the cost of health care in the state are the benefit mandates and regulations it places on the insurance sold here, the healthcare taxes it imposes, and the underpayment of doctors and hospitals through our state public programs. The legislature hears from us often about the impact of benefit mandates and the impact they have on the cost of care. But the underpayment of doctors and hospitals by public programs has become an increasing concern for those who provide and pay for coverage in the commercial market. Because programs like Medicaid often pay these providers less than what it costs to deliver care, pressure has continued to mount on commercial payers to make up the difference. Because of this, our members have asked us to encourage policymakers to address the growing cross-subsidization of public programs by the commercial market. Very helpfully, Senate File 1402 would begin to do just that. However, we are concerned that the adoption of the A1 amendment undermines the benefits of the bill's rate increases by funding them through a new tax that will increase the cost of health insurance for those who rely on coverage in the state-regulated, fully insured market. This is particularly troubling at a time when recent state budgets have drained hundreds of millions from the Healthcare Access Fund and spent billions in historic state surpluses, all without addressing the need to right-size public program rates. As I said at the outset, healthcare affordability for employers and their employees is not getting easier, and the imposition of this new tax, potentially in conjunction with other new healthcare taxes being proposed and discussed this session, will push costs higher. We believe the state has a responsibility to make good on the promises that it's made to the enrollees who benefit from our public programs and the providers who care for them. But we do not agree with an attempt to fix this problem by adding more costs to those in the commercial market who are already struggling with affordability and who are already paying a significant premium to subsidize low public program rates. Thank you, Madam Chair. I appreciate the opportunity to testify.
Thank you. Mr. Zeidner, please introduce yourself for the committee and proceed.
Thank you, Madam Chair, members. My name is Dr. Lou Zeidner, and I'm the CEO of EOSIS, formerly known as Meridian Behavioral Health. EOSIS has been providing substance use and co-occurring mental health care to patients throughout the state of Minnesota for over 25 years. We have 13 residential and 7 outpatient programs from East Grand Forks to Owatonna, from Stillwater to Waverly. We represent about 25% of the Medicaid beds for these services in the state. While our state statutes differentiate substance use disorders from other mental health disorders, the symptoms of our patients and their care needs do not differentiate as clearly. Most of our patients have a combination of substance use and mental health conditions and treatment needs. In addition to crossover patient needs, many clinicians work with patients that have both substance use and mental health needs. Minnesota's very low Medicaid reimbursement for both substance use disorder and mental health impacts us in 2 ways. As an organization, we lost money last year in the millions of dollars. Our labor costs, lease costs, food costs continue to escalate, while our revenue from Medicaid care that represents 90% of the care has remained stagnant. Our labor rates are increasing because qualified clinicians and support staff are able to be paid significantly more by systems that primarily serve commercial insurance patients. And similarly, they are pulled across our borders to adjacent states that have substantially higher Medicaid rates. We recognize that the legislature has many priorities to address and that available monies are tight. Nonetheless, if we do not receive material relief in the form of rate increases and a path to sustained rate increases, our creditors will force the closure of our programs, and that will create a crisis of access to care in multiple communities across our state. Effective treatment for substance use and mental health disorders reduces downstream costs in medical care, corrections, and general community challenges. We urge the committee to support this bill and support rate increases for substance use and mental health care. Thank you.
Thank you. We do have one testifier on Zoom, Leah Seeger.
Good morning.
Good morning. Go ahead, introduce yourself and proceed.
Thank you, Senators and Madam Chair, for the ability to be here today. My name is Leah Seeger. I'm a licensed marriage and family therapist, and I'm here as the president of the Minnesota Association for Marriage and Family Therapy, which represents the 33,300 marriage and family therapists across the state. On behalf of my members, I'd like to express our support for SF 1402 because it addresses a significant pay disparity that currently exists between individual and family therapy services. Current MA rates for an individual therapy session, meaning one therapist, one client, is around $130 for a standard therapy hour. Meanwhile, a reimbursement rate for a family therapy session, which is one therapist and maybe 5 people in a room, is $70 an hour. This makes no sense when family therapy services are specialty services and are often more complicated work. As a result of this disparity, many of the providers in my field are choosing to forego taking MA or forego taking insurance altogether and develop private pay practices that are cost prohibitive for the majority of Minnesota families. While I support my colleagues in finding ways to adequately be compensated for the work they do, this creates longer wait times for the remaining providers who take MA and further reduces access to care, especially for historically underserved populations. I myself am a provider who accepts MA, and I specialize in trauma and addictive issues in families. My current wait list is over 9 months long. It is far too long for any family to wait for support. Adopting the rates proposed in this bill will address this disparity, taking family therapy services from less than 40% lower than an individual therapy hour to approximately 10% higher than an individual therapy hour. This legitimizes the amazing work the individuals in my profession do and incentivizes providers to take MA, work with more families, and increase access to quality care for all Minnesotans. Thank you for your time and your consideration. I'm happy to speak more about my profession or the effects of pay parity and how this bill addresses that issue.
Thank you. That comes to the end of our testifiers. Senator Wiklund, did you have anything to say at this time before we take questions?
No, I don't have additional thoughts.
Very good. Members, questions, comments? Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Wiklund, we've kind of had some conversation already around this. I guess I'm going to start with my first question, which is related to the services that are covered in this rate increase. Can we talk about, like, I know it's referencing all physicians, or at least it seems to be referencing all physicians. Are there any that are being left out? And then with the reference to Medicare, are there services that we're leaving out because of that? Do you have any answers to that, or maybe somebody can help you with that?
Senator Wiklund.
Yeah, Madam Chair, Senator Liskey, there's kind of two parts to your question. I don't know if DHS would be able to comment about what globally is included in the lines 10.8 through 10.11 in terms of the what is considered all physician and professional services, if that would help us kind of understand that point.
Mr. Hayes, welcome to the committee. Introduce yourself and proceed.
Thank you, Madam Chair and members. Giogo Hayes with the Department of Human Services. Senator Liskey, to your question. So one, just to orient the committee, the term physician services here is not a service delivered by an MD. Physician services is a category under federal law of services that we cover. So just so everybody knows, it's not about MD services in this case. We today in the Medicaid program already use this payment methodology, the RBRVS, the resource-based relative value system, for a large chunk of our services. So about 9,000, between 9 and 10,000 codes are using this service, or excuse me, this payment methodology. All this bill does is say, today we pay this much for the same bucket of services. If this were to pass, you would pay this much. So anything today receiving that payment methodology will continue under this particular legislation.
Senator Liskey.
Thank you, Madam Chair. Thank you. I think that answers part of it. I guess the other part of the question is that, unfortunately, the federal government doesn't always cover the same services that Medicaid does. And so there's a laundry list of services in that realm. Do we know what we're going to do with that reference? Are we going to leave those rates the same? Are we going to increase them to match what would be equivalent to a Medicare rate? How's that going to be handled in this bill?
Mr. Hayes.
Madam Chair, Senator Liskey. So any service that we cover will obviously continue to be covered under this bill. All the services that we pay for have some methodology somewhere in state law or state rule. And so if it's a service that we cover that Medicare doesn't, we already have authority somewhere else to use it. So in some situations, to your point, there are services that use sort of a percentage of Medicare or use a Medicare crosswalk or something. So if that's a tie that exists in statute or rule today, that will happen here. So as a tangible example, let's say there's a service that says, use something similar, 20% of something similar or whatever, we would just take that new rate under this bill and then take 20% of that or something like that.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, a different type of question for Senator Wiklund or for DHS possibly to answer. With this change, the amendment A1, obviously it's a pretty big change to the bill, as we heard from some of the plans and things of that nature. I guess my concern is, well, first I'm going to start with an easier question, I guess, is do we know what other states have enacted something of this type of payment methodology?
Senator Wiklund or Mr. Hayes?
I'm not sure that he would be able to comment. I would ask maybe if Dave Renner is available to talk more about that. They have, the MMA has been working closely with consultants and can answer that question.
Mr. Renner, welcome to the committee. Introduce yourself and proceed.
Madam Chair, Dave Renner with the Minnesota Medical Association. Senator Liskey, yes, there are, the methodology that we've used in this bill is based on what has been passed in a number of other states, both red and blue states. The two that we've looked at most is California and West Virginia. And the reason we've looked at those two is that they've structured it in the same way that this bill does, with the different tiers to maximize federal matching monies, but minimize the impact on payers. So of the total amount, as Senator Wiklund said, that we raised through this assessment, 99% of it will be reimbursed to the payers through their higher capitation rates and medical assistance.
Senator Liskey.
Thank you, Madam Chair. Thank you for that information. I guess my concern that I had, and I have addressed kind of with Senator Wiklund, but maybe you can help me answer also, is what happens, I mean, our federal government is changing. It always is. There's, no matter which party, what administration is in the office, decisions change based on who's there. Are we concerned that just because these other states already have passed this and already have access to it, that it could either A, get cut, or B, just not be accepted for our state? And do we have a plan if that doesn't happen?
Senator Wiklund or Mr. Renner?
Madam Chair, Senator Liskey, I can't predict what the federal government will do, but in this mechanism that we're using was approved by Congress. CMS in the past has raised some concerns with it. They have attempted to limit it, and because it's congressionally approved, that has not been able to be done. What we've seen on the books or on the potential changes to these types of funding mechanisms, limitations on that, what you have before you would still fit within those limitations. Again, this is a mechanism that's used by, I think, over 40 states, both red and blue, and there's a number of governors and legislators from those states that are very nervous about CMS taking this method away, so we're relatively confident.
And I think also what you're trying to say is that we've never had a federal government threaten to cut $880 billion from Medicaid before, ever. So it's something we have to consider for sure. Senator Liskey.
Thank you, Madam Chair. Thanks for the little extra information. I guess at the end of the day, I'm concerned that who's gonna foot the bill if this does change? What's the plan? What's the fallback? What's the off-road or off-ramp in this case if something does happen where it's not approved? Who's going to pay for it, I guess is what I'm asking.
Senator Wiklund.
Madam Chair, Senator Liskey, in the bill, not the amendment, there are clauses where capitation payments are referenced, and it states that, if for any contract year, federal approval is not received for the subdivision, the commissioner must adjust the capitation rates paid to reflect the removal of the subdivision. So I believe that it is structured in a way that if we enter the program, we receive the extra funding, but then it gets turned off, then we have a process for DHS to revert to perhaps a base year. I don't know exactly how they would state that. I don't want to state it incorrectly, but that we would go back to prior rates.
Senator Liskey.
Thank you, Madam Chair. Thank you, Senator Wiklund. I appreciate that answer. I guess that kind of helps me enter into the last line of questioning that I have, and we've kind of talked a little bit about it, is, sorry, I just lost my train of thought. Basically, the question that I was going to ask is, nope, I lost it. For now, I'll have to come back to it, sorry. Thank you, though. I appreciate it.
Members, other questions? Senator Port.
Thank you, Madam Chair. Thank you, Senator Wiklund, for bringing this forward. I think one of the things that really strikes me about this plan is it thinks about two of the biggest struggles that we have, which is patients having to wait too long for care or not having access to care, and also providers and clinics, particularly in greater Minnesota and underserved places, not being able to stay in business. I appreciate that this addresses both of them in a way that has the least impact on the state's budget and Minnesotans' pocketbooks. So I really, I think there's a lot of value here. I just have one question. If in the future, because one of the things talked about at the federal level is moving to block grants, can you talk about the impact that moving to this would have on the state of Minnesota if we move to block grants?
Senator Wiklund.
Madam Chair, Senator Port, I'm trying to think of, I don't know if I could answer that question very well, and I'm not sure if DHS would be able to answer that. I mean, it seems like a block grant would present the state with a certain amount of money. I don't know if that means that some of these payment programs would be discontinued in that same effort. And then the mechanism for us to allocate the block grant, you know, as a state, we'd have to make decisions about that. So it probably would have a big effect on how we decide how to, you know, pay providers and then the rates. But I guess I don't know if I can give a more specific answer than that right now.
Okay, Senator Port. Senator Abler.
Well, thank you, and appreciate the creativity. And I want to thank all the people that wrote every letter. I think I've helped every one of you at some point along the way to try to keep open, flexibility, serve people. And I think if you would query the committee here, we're all in favor of helping you all stay in business and serve. I think we're all aware of the challenges in any Medicaid rate. If you work for Medicaid, you are going to go out of business, pretty much. And I think we're also aware of the challenges at the feds. 21 of us wrote a letter to the feds saying, please be thoughtful and remember we have a job to do. And so we get it. But I have an amendment coming. To this topic and to the mechanism, part of the problem that we're in at the feds and here, and we're actually in the same country, is that been the endless chase to get more federal money from Uncle Sam. And at some point, the parent gets broke when the children spend too much money. And I'll include myself as one of those, like, oh, let's get free federal money. It's falling from the sky. All the COVID money, we got $84 billion during COVID, a lot of one time, a lot of which was squandered on things or built into base funding that now we're facing cliffs from. This program as well is going to create base funding, and in 2030 there's going to be a cliff, which is actually when the big deficits start to hit. So I just want to caution you, and I'm concerned that as we ask the feds for $1 billion after we arbitrage $800 million, that $800 million we're talking about now, it's $881, and I don't know why they're going to approve this. Maybe they will. Personally, I do not support this mechanism. I support the bill. I support finding ways to do it. And you can't go back in time and change what you would have done. But maybe if we would have remembered all these people and all the services we're not doing 2 years ago, we would have spent our money different when we had a ton of it. And so I just want to remind the people cheering for all this money that the hospital money comes in 2028, the home health money comes in 2028. The doctor money comes in 26, which is the more normal rate of time. So I think we have to ask the committee and the world here, are we going to continue to chase federal money from our uncle who meant really well and had too many programs that were too encouraging too much matching and so on, to the point we're going to have a hard time maintaining what we do have? Or are we going to find a way to make it work out? How do we triage our essential, important, and nice? In 2011, we had to do that. Again, the push came to shove for all kinds of economic reasons. So I just want to caution us, and I even want to remind you that the MNsure subsidies, the MNsure program up to 400%, is funded by federal subsidies, And if the health plan costs go up, those subsidies are going to go up. And that alone is going to require more federal money, which is going to just crash some of the things we care about. So I just want to caution us about that it's none of this, there's no free money anymore. And there's whatever you think of the trifecta there, it's there. And so we saw I'm not impugning the governor for what he did, although I do not like his bill at all. He actually called me, chat. And so, level setting. Okay, level setting. Let's work on this and figure out how we're going to rescue Minnesota. But so none of us like the $1.5 billion reduction in this part here, which is a comparable, if you take 10 years of $888 billion, and our share is about the same number. So we have people we have to serve. We have to make some hard choices that I hated in 2011, but we did to manage the money we have. And I'm just worried this is going to create expectations and a future deficit that is not going to be useful. And so this committee has a responsibility to handle hospitals and EMS systems, which frankly, when we handle the money, we didn't do it. We didn't even do rebasing. We didn't give any meaningful EMS support to people, so when they're at the cabin or in their home up in greater Minnesota, they can actually get a ride to the hospital, which still limps along being open. So anyway, with that, Madam Chair, I'll move the A3 amendment.
Senator Abler moves the A3 amendment. It will be handed out. While it is being handed out, Senator Abler, do you want to speak to it?
And so this actually, and so the premise of this bill, I don't know how many $20 million there are around that we're going to be conjuring in this committee, but the premise of this bill is that, thank you for all of you doing all this stuff, but that this is the very most important thing with the money we do have to spend. And so I think if everybody knew in the industry that this was all we're going to get, $200 million, what would we buy with it? Would we buy some of the fees that people would like? This actually gives it to EMS, which I think is a need. If we have to choose essential, important, and nice, I think people that are in their cabin having an anaphylactic shock from a bee sting or a walnut should have access to not die. And we've long heard about that as cities are actually property taxing themselves to have any kind of service. And so I don't intend to take a vote on this, but I want to make the point. It's easy to offer people free money. It's hard when it's the money we have, and we have to find a way to triage and really focus on what's important. I think that some of the errors of the past, both on the part of the feds and being too generous with some of these matching programs, now put us at risk. 90% match on the single adults was a great thing. Spending the healthcare access fund money down to almost zero to leverage future things. Actually, Mr. Renner, you and I disagree with how they spent that money. It was kind of good at the time, but the chickens are coming home to roost. And so I am here to be part of the solution. This committee is the vector for handling the very groups that are here to handle those needs. How are we going to handle them in a real way and in not a way that, I think this amendment's a myth. I do not think it's going to be approved. And I do not want to burden the health plans anymore, even though I'm not always a fan of them. But so I made my comments, and I tried to get them into one chunk here. Mm-hmm. This is not going to be an easy time. And if we think we're going to continue doing business as we did before, we're in error. So with that, I'll withdraw the amendment, and I'll sit quietly for the rest of the bill. Thank you, Madam Chair.
Senator Abler withdraws the A3 amendment. Senator Wiklund, response?
Thank you, Madam Chair. Senator Abler, thank you for the comments. I hope that, I think coming up with a way to solve our initial, what we're trying to solve with this bill, it doesn't mean that I'm thinking that we are totally, not going to be affected by all the other things that are going on. We are trying to find a way that is within our control as a legislature to address an issue that has been building over many years, and we haven't been adjusting our rates upward, and we can see the result of that. Is it the only way to do that? You know, could we do it in a different way using resources, you know, within our state? I think that it's possible, but it would also require other choices to be made, and this seems like a way we could take advantage of a methodology that is in place today, but we don't know, you know, what's going to happen in the future. It would allow us to move forward with implementing higher rates now. I think that you and I probably would disagree about what all of our options are to solve some of these issues that we're facing. I mean, I think that, yes, this year is going to be very difficult because of the choices that we're going to need to make, the political makeup of our bodies, the House and Senate. But if you're going to talk about, you know, overall, what choices could we make to solve our problems, I think, you know, we could talk about many different ones that you and I maybe wouldn't agree on. So we have to come to some agreement on a way forward that we can, enough of us, agree on. I think we do face challenges that we're going to have to address in our committee about the budget. This bill attempts to find a way forward in a difficult year for us, budget-wise, and would give us some hope of being able to increase rates in a substantial way. And I think it's worthwhile to make that attempt to do that. I understand that the federal government, you know, it won't be able to provide endless funds to us. But I do think if there is a reasonable way for us to put a mechanism in place that can be supported with additional federal funding, I think we should try that. Because I don't see a way with our current situation that we are going to be able to put the substantial amount of money, you know, $300 million over biennium to address rates. We just don't, in a sustainable way, we don't have a way to do that. And we can look back 2 years ago, you know, maybe we would make different decisions, but I think a lot of the money or a lot of the funding we had was not ongoing money. We would have been facing some of the same challenges in the future because it was not ongoing money. So we can second guess what we chose to do, but where we are at right now, I think this is an option that could help us and help providers. And then the bottom line, you know, help kids and families across the state.
Senator Utke.
Thank you, Madam Chair. And we've had a lot of good comments around the table here already, so hopefully I won't repeat some of those, but I do appreciate what's been said. The heart of the bill, I don't think anybody disagrees with. Our Medicaid rates are horrible, and everybody that comes before us talks about the challenges we have. And I mean, there's not a day that goes by that, whether we're here or home, that we don't hear about the Medicaid rates and how they aren't keeping up. But on the other hand, the rest of this proposal, I got a real problem with. It's another tax on the commercial plans, and there is no offset on the rates, and that's the problem part of it. We know the problem is the reimbursement rates of Medicaid. Let's, in my mind, let's get serious about trying to, I think there's a way to do it without having to raise these costs. Our commercial market is already small that this would affect. We've got a lot of hardworking Minnesotans that are in that market, and a number of them have given up on insuring themselves and their families already because premiums are too high, and this is only going to make it worse. There's got to be a better way, and I know that we can do that. I had one of the things that I believe is in there, a couple questions to kind of follow up on that. The assessments, are they currently planned, if this was to go forward, would they be held and deposited into the general fund?
Senator Wiklund.
Mr. Chair, or Madam Chair, Senator Udke, it would be deposited into the Healthcare Access Fund. That's on, I'm not sure if I can find the.
It's on 4.4.
On line 4.4.
Senator Udke.
Okay, well, that's good, because that was the concern, at least if there was to be something. It's held in an account that's, that can be tracked that way. But going back to some of the comments early on that there was a partnership on this proposal, I believe this finance funding mechanism of basically taxing the plans is something that just recently came together, and I don't believe that there is a total partnership on it. Am I right or wrong on that assumption?
Senator Wiklund.
Madam Chair, Senator Udke, I think the hope is that we have been talking about, stakeholders have been talking with the plans about it. We're hoping to find a way that is amenable to plans and to the way we can implement and draw down the funding, that we could work something out that would be agreeable. I certainly understand from testimony that they are not, at that point right now. I would say that the comments about the commercial market, the way the assessment is structured, the assessment is much, greater on the MA population as opposed to the commercial population. If you look at the dollar amounts, the state money raised by the MCO assessment would be about approximately $748 million. The MA population assessment would be $747.1 million. The commercial population assessment would be only $1.7 million. So I really would like to talk with the plans more and the chamber and understand better this concept of, the commercial plans being burdened, and maybe we can understand better why they think that the way it's structured would really impact commercial rates.
Senator Udke.
Thank you, Madam Chair, and thank you, Senator Wiklund. Just a follow-up to the numbers on the various plans. Even though those numbers that you just showed us were smaller on the commercial side, it still drives up the costs. I mean, that's the only place they've got any wiggle room, and that's where it's all going to fall back on if they're, if they have to make up cost shifts, et cetera. And that commercial market is a small group. So that's where I'm concerned is they are already overtaxed, overburdened, and not able to afford their premiums. Any movement is too much, I guess, in my mind, but, so that's where my concern comes in. We hear regularly how they're struggling, those that are still trying to buy their own insurance and provide for their families. It's tough. But one last question. There's a lot of fiscal costs, and I'm sure it's a very involved fiscal note, but do we have any idea yet what we're looking at on some of those costs?
Senator Wiklund.
Madam Chair, Senator Udke, I think, we've gotten very preliminary estimates from DHS because several months ago we started working on this, and last year we're starting to work on what would it take to implement the rate study. I think we only have very preliminary cost estimates, but that's where I mentioned the over $300 million to implement the rate proposal, and that is an estimate that isn't based on the exact language. So I'd really rather get a better fiscal estimate now that they have the specific language to work on, and that work is in progress.
Senator Udke.
Thank you. That's all. Thanks.
Senator Curran.
Thank you, Madam Chair. And Senator Wiklund, Senator Abler also covered a variety of issues about the cost, right? And we think about back in 21-22, I think our spending for the state for the biennium was $108 billion, right? That was the biennium spending. Its general fund was 52 at that time. Another $84 billion came in, federal, and into the state of our federal money. And the drunken spending at all sides during that period of COVID and since then allowed every functional unit of government. The cost to our citizens has risen exponentially. In addition to the expansion, it's maybe not related, but I think it is all related from the perspective of the expansion of Medicaid and qualified services, and the number of people using it, and the cost containment or the lack of any cost containment is creating and compounding the entire problem here. When you look at all of the issues that we're dealing with, or the expansion of Medicaid translation services, Medicaid transportation, Medicaid equipment, Medicaid autism services, adult daycare, child daycare, all of these things are a component. PCA services. It's just an ever-growing list. We're dealing with sober homes and, again, additional qualified services that have grown significantly. And at the end of the day, the utilization, we care, I think everybody here, we all care, how do we solve the problem? I think this is a tax on a very shrinking group of the people paying 100% of the freight, and now they have little access to that very healthcare system that they're paying for. And yet we're not seeing anything on the other side. How do we get some type of cost containment? We know they're bearing it, right? The providers, the plans, and everybody's bearing this cost. When we have such a huge portion of our population in Medicaid today, Minnesota grew it faster likely than any other state. And when you go out and see the utilization and you see the stories, and my wife had a bizarre medical incident in, I think, May last year, and raced into ER in St. John's Hospital. Happened to be global transient amnesia. So you lose the ability to create short-term memory for a day. Kind of bizarre when you lose a day. But it presented as a stroke, so we got in. Having a conversation, sitting in that ER. That was on a Sunday, 11 o'clock, 12 o'clock. And that ER looked like a disaster zone. They have, what, 40 or 42 beds or something like that in the ER. And after our emergency kind of calmed down a little bit, because we never turn off our role in serving in this role, I asked the nurse, I said, what's this look like every day? And because there were patients lined up both sides of the aisle, right? The temporary nurses station rolling there, a family member standing there waiting, and a patient in a bed. And they said, it's like this every day by 10:30 a.m., 7 days a week. And so then I asked her, I said, all right, what's the mix of patients, right? And tell me, just an honest assessment, is this convenience care or are these true emergencies? And she said, yeah, and I know it's anecdotal, but it's 50% convenience care. And that's the Medicaid side. And so we've got them using the most expensive services that exist for convenience care. And I think Senator Port said the same, or said those challenges are driven because it's very difficult to get appointments. It's extraordinarily difficult for people who are paying to get appointments as well. And in this case, Medicare appears to utilize services because they have skin in the game, right? There's a direct cost of when they utilize services. The commercial market, right, there's a direct cost. Most can hardly afford the premium, more or less, to use their health insurance in that limited access and waiting time. And then we've got another pool that utilizes it at will in the most expensive manner that exists, and it's a challenge for everybody. But what I don't hear is anything, how are we going to solve that side? So from the utilization between telemedicine or make an appointment for your sore knee, how do we work on those aspects? Because that is, if we don't touch that, none of this does anything to do this besides continue to fund more of the same, and there's no challenges there. And again, I'll go to my 3 months ago, I did a Hennepin EMS ride-along. Go ride along there and find out a significant portion of their calls that rise to an emergency, right? The highest priority are for convenience care or transportation. And when you look at the number of resources on a high priority call in Hennepin County, and I give them great kudos, that was an amazing process. They are heroes. You look at what they're doing. We sent an EMT, right, an ambulance with 2 EMTs, an engine company with 2 EMTs, and almost every call we went on had at least 2 Minneapolis police officers, sometimes 3, depending on the venue. Every call averaged about 45 minutes. Everybody that should have went to the hospital didn't. Everybody who shouldn't go to the hospital did, into the ER services. And we just don't hear anything. And it's all chasing the same dollar. The federal, right, the bane to our existence as a state legislator, I think, is terrible federal law, crappy federal law, which really restricts us being blackmailed for utilization of our own money, which is, that federal dollar is ours as well. And we don't seem to be bending the curve on how do we address those challenges. So I think we blew $18 billion. We moved $1.2 billion out of the Healthcare Access Fund. We had all those things. We already have existing channels. But we're not trying to bend the curve on the other side. And we understand it's catastrophic. Every single provider, I think all those letters came for the last 5-6 years. Huge surplus, we blew it, and we still didn't address any of the real critical needs. This is one of them. The cost and how we raise the rates is one. How do we bend that curve? And you all are experts in this field. How do we bend the curve to try something creative on that cost side? Because it's absorbing all of our general fund money, including our schools. So I know I don't have a question. You guys have already asked all of them. But those are the things that we've got to focus on, and I don't hear any of that. And how do we bend that curve and say, well, we can't restrict? I'm not talking about restricting access for Medicaid. How do we bend that curve for the utilization at the appropriate level and through the appropriate resource? Every single one of you are having that challenge. Every single ER room and every medical provider in the entire state's having that issue, along with the plans. So that's, I think, where we're going to have to spend a majority of our time. I don't think the new tax is going to help us. Again, put a further burden on the people who are paying the majority of the freight today, both through their income taxes and all their healthcare utilization, and they don't have access today. So how do we bend that curve? So Senator Wiklund, we'd love to get creative. Everybody in the audience here, all those for, all those against, this not against increasing the care and the rates, but what are we going to do differently to try and bend that curve? Because it's probably the single greatest threat to all critical access that we need to provide. So thank you, Madam Chair. Or thank you, Senator Wiklund.
Senator Wiklund response, and members, I will give a gentle reminder that we do need to keep moving on our agenda, but this is an important conversation, so I don't want to cut anybody off. Senator Wiklund.
Thank you, Madam Chair, Senator Cran. I think that, I guess I'll separate just a couple parts to respond. I mean, I think looking at where to contain costs is a very valid proposition, and I think we should be looking at how do we address the rising costs of healthcare for everyone. And in previous sessions, we have had discussions in this committee, and we should continue to have them, about what can we do as a state to try and influence rising healthcare costs. It is a challenge because as a state, I think the influence we have over some of the segments of the market, for example, the employee-sponsored insurance market, we don't have much influence over that whole segment. So I think that's a valid point. You know, we need to work on that in this committee because, yeah, our rising costs are not sustainable for us as a state or for people in their daily lives. I think the other aspect of what you were talking about in terms of Medicaid utilization, I just would like to say I'd really rather sit down and maybe we should talk about how Medicaid services are utilized and where, you know, the costs are being borne and who is using services. I would hesitate to state that, you know, convenience care is majority of people in that sort of category are Medicaid patients, like in an ER, and it seemed to me you're implying that people using Medicaid maybe aren't using the most cost-effective services when they need them. I guess I'm not sure I would agree with that. I think people sometimes use the ER for care when they should choose a different source of care. But I don't think that I would say that, that the majority are Medicaid patients that are choosing that and could be choosing something else. Some of the rates that people are paid for some of the services today, they just aren't covering their costs, and that's what we're really trying to get at with this bill, so that people are able to access through an MA provider, they're able to access the appropriate care they need. If they can't find a provider who accepts medical assistance and they need access to mental health care, we risk them developing more complicated, complex conditions that require even higher levels of care. So I think the foundation of this is to get our Medicaid rates increased across, a broad number of services, and especially focus on outpatient mental health, so that people are able to access the appropriate care at the time they need it.
Senator Mann.
Thank you, Madam Chair. And I don't honestly know that has anything to do with this bill, but I've heard this speech more than once now, and I wasn't going to say anything, but the fact that I've heard this speech more than once now, I can't not say anything. This idea that you have spent a day in an ambulance and now you can explain healthcare is so absurd to me that I can't, I don't understand it. The idea that because you have MA, you can now walk into an ER and use healthcare willy-nilly, and that's the way healthcare works, is absurd, right? People with the best health insurance will walk into any ER at any point in time because they don't want to wait 3 weeks for a clinic appointment. People with the best healthcare, with wealth beyond means, will walk into an ER because they have a bump on their skin that they don't want to wait 2 weeks to see a clinic appointment for. So it is not people with MA and poor people who are using the most expensive health care. That is such a false narrative, and it is so offensive. And I want us to stop doing that to poor people because it is not right and it is not fair. And if we want people to stop using MA, then maybe we should stop taking all the wealth from the middle class and giving it to the top 1%. Maybe we should stop transferring all the wealth and giving tax cuts to the wealthy and making it so that we rob the middle class and making poverty more and more prevalent and making it so that more and more people have to use MA because we take all their money by making policies at the federal government and at the state level where we don't care about poor people, we don't care about their plights, we don't care about what they're going through because we think that trickle-down economics and all the other bullshit that happens, that we take money from people that we don't think earn it, and we think that poverty is a character flaw. I'm just rambling now because I'm so angry. The point is, we have to stop robbing the middle class. We have to stop increasing poverty, and then we turn around and we blame them because they need more things. And again, the idea that only poor people use health care inappropriately is false. Thank you.
Senator Port.
Oh, great. I get to follow Senator Mann. Part of what Senator Mann just said is what I have circled on my paper. The transfer of wealth to the richest among us has made this social contract that we have in our country, that the poorest among us deserve access to health care, deserve access to housing, deserve access to nursing homes, deserve access to mental health care and education, and all of these things. We have a social contract. And right now, as part of that social contract, the federal government is supposed to be our partner. They are not our enemy, they are our partner. And this policy and the amendment that you brought make sure that we use our space in that partnership to serve the people of Minnesota to the best of our ability. Do we know what's going to happen at the federal government? No, we don't. We know what the Republicans passed in the House last night. We know that it cuts $880 billion from needed health care and nursing home care and mental health care from the people who we have told we will have your back. Yes, more people are on these services right now because we have the largest population of seniors ever in our country entering poverty in their twilight years. They are not living like this retirement life of leisure. They are barely getting by. And we have a social contract with them that we will care for them. We have an agreement that we will do that. And maybe the federal government is going to cut $880 billion from that agreement. But we're not in Minnesota. We're not going to do that. So we're trying to find ways where we can partner with what is allowed through the federal government right now, which this works, and we will still be under the allowable percentage that we can get back in reimbursement. And I have a lot of empathy for people on the private health market. Before I was elected, that's where my husband and I got our health insurance because we own our own business. It is expensive. And that's a problem that we should be fixing. But I also want to I want us to understand that this has to be an all of us together solution. In Minnesota, United Healthcare last year had profit of $14.4 billion. Blue Cross Blue Shield had $103 million. Health Partners had $15.4 million. Medica had $257 million in profit. They can be part of the solution. This is not us against them. This has to be all of us together to fulfill the social contract that we have, that people get a base level of care when they need it. We are not asking for the moon. We are asking for people to be able to go to the clinic and see a doctor. We're asking for children to get mental health services. This is not outrageous. This is the contract that we have with the people of Minnesota. And Senator Wiklund, I am grateful that you are fighting for Minnesota to keep our part of the promise.
Senator Liskey.
Thank you, Madam Chair. And after this wonderful discussion, I got back to the questions that I had. So we're going to change the temperature of the room a little bit again. This is the area that I probably have the most trouble with the bill and where we're at, and with more specifically the amendment, because the bill I was heavily in support of, hence the co-authorship. DHS might have to come up to answer these questions, but looking through this, the how we're going to pay for it mechanism, the tax on the plans as it's written, is based on enrollees. And something that I know about health insurance more than anything is that the enrollees go up and down pretty significantly throughout even the year, much or less, across a 4-year span. I think that's projected in this bill from 2026 to 2029. The concern I have is what happens when a plan decides to drop MA coverage? Do they no longer have to pay the assessment for those MA enrollees? How I guess when their plans are changing, when their enrollees are changing, how do we handle that? How do we address it?
Senator Wiklund.
Madam Chair, I think it's, and Senator Liskey, I'll let Mr. Renner answer if you look on page 3.27, and I'll let Mr. Renner elaborate more on what would happen.
Madam Chair and Senator Liskey, we've had conversations with the plans and the concerns as you raise about what about enrollment changes. What we've tried to do in this is try to have a kind of a snapshot of a 3-year period, which in other states that has been something that the health plans have asked for because it gives them predictability and they know what their amount is. We do have language, as Senator Wiklund says on page 3, that does allow the commissioner, if there's an acquisition or a merger or somebody drops out of a program, to way to adjust those numbers. We're willing to continue to have conversations. If 3-year snapshot is too long, should it be a 2-year snapshot? Again, in other states that have done this, the health plans have asked for that stability and predictability. And again, there's some other areas where we give the commissioner some authority if there are major changes in the market, and we're willing to look at those too, if that would help.
Senator Liskey.
Thank you, Madam Chair. Thank you for that answer. I guess the other thing that I'm concerned with is when I read through that language on page 3, starting at, I believe, 3.19 is what you're referencing. It kind of, basically, the commissioner, the whole page of page 3 talks about the commissioner being in charge and deciding whether they should or shouldn't reassess this. And my concerns are that we're going to run into with the acceptability, the word may is the part that I think is probably the most concerning, is that it doesn't mean that they have to. And so the plans are probably pretty nervous if it's a may and not a must, right? They don't have to reassess. They could have these bills happen. Let's say there is a merger. Let's say that Medica merges with United Healthcare, which, I mean, they're already kind of related, but let's say they have a huge merger. Are they on the hook for now the Medica and the United Healthcare assessments? What's going to make DHS, what's going to make the commissioner change their already assessment on the plan? I don't feel like reading through this that I'm getting a side of the government has to respond to those types of situations.
Madam Chair and Senator Liskey, again, that's the intent. If there's language that we can work on with DHS and with the health plans to strengthen that or to make that clear, we're happy to do that.
Okay.
Senator Liskey.
Thank you, Madam Chair. I guess at the end of the day, once I've kind of expressed where I'm at, I'm in support of the initial language. I'm really having a hard time with the amendment because I think there's a lot that needs to be worked on how the amendment might work. I am concerned that it is a new tax, that honestly it just is a pass-through. It's going to be passed on to those that are paying for their health insurance. I get concerned when it's a creative idea, and I look forward to having more discussions on the creativity of how it's going to work. But I am concerned that all it does is raise the cost of health care in the end. And that's not our goal. I think our goal is the access. It is to keep the providers in place because obviously I think, as a provider myself and as providers that I communicate with every day, the discussion of moving away from accepting insurance altogether is another discussion that providers are having. And that will limit health care access to the individuals that Senator Mann has expressed are people we need to take care of. So I'm worried about the system as a whole. I'm concerned that it's not working today. And as Senator Port said, I think we all have to at some point come to the table and stop worrying about ourselves and start worrying about the whole problem. And so today I'm not sure where I am at. I think I'm a no just because of the amendment for today. But I look forward to continue working on it with Senator Wiklund and trying to get this language a lot more narrow and specified. So thank you.
Senator Wiklund, any closing comments before we move to a vote?
Thank you, Senator Boldon, or Chair Boldon, and Senator Liskey. I mean, I would commit to you that, the amendment language, I'd be happy to continue to work on it with you to make sure that it would accomplish what we want it to accomplish and not have negative impacts that were not intended. I think the intent of the bill is to help Minnesotans, get better access to health care where we see issues today in terms of, needs are not being met. It's affecting Minnesotans, and one way to influence that is to increase the rates, make it more possible for providers to cover their costs, and then, people will have better access. So I commit to keep working on it. I would like to move that Senate File 1402 as amended be recommended to pass and be referred to the Tax Committee. That's my motion, Madam Chair.
I would request a roll call.
Roll call requested, roll call granted. Clerk will take the roll.
Chair Wiklund?
Yes.
Vice Chair Mann? Yes. Lee Dutke?
No.
Senator Abler?
Can I vote yes on the first half and no on the second half? All right, no then, thank you.
Senator Boldon?
Yes.
Senator Hoffman? Senator Cran?
No.
Senator Kupek?
Yes.
Senator Liskey?
No.
Senator Port.
Yes.
There being 5 ayes and 4 noes, the motion passes, and Senate File 1402 as amended will be recommended to pass and re-referred to taxes.
Thank you, Madam Chair. Senator Boldon, Senate File 477.
Thank you, Madam Chair. I do have an author's amendment. If perhaps we could move that first, I would move the A1.
Senator Boldon, I see an A2 amendment. Is that the correct? Okay. Senator Boldon moves the A2 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A2 amendment is adopted. Senator Boldon.
Thank you, Madam Chair and members of the committee. The rationale behind the bill before you today is straightforward. We are all aware that increasing access to mental health services is in need in most every part of our state. A key piece to increasing that access is attracting and keeping mental health care staff. To keep mental health care staff, we must address areas in statute where outdated, overly prescriptive, or confusing regulations are taking staff away from direct mental health service provision. This is leaving staff feeling like they are spending more and more parts of their days on paperwork, resulting in burnout and turnover. We must also work to address areas of state regulation that we see are closing the door on interested new mental health care staff. The bill before you today represents many months of mental health stakeholders collectively working together across the mental health legislative network and other partners to identify specific areas in statute where we can update mental health service regulations to better fit today's needs. This bill language was shared with the Minnesota Department of Human Services in early fall, and the bill proponents have been working with DHS since that time on their feedback. And pieces of that feedback are reflected in the amendment that we just adopted. There are a few outstanding sections of the bill where bill proponents remain committed to continuing the conversation with DHS towards language that all are comfortable with, and those conversations are ongoing. The intent for this bill is to be policy only with no cost. If any of the provisions are flagged to have a cost, those will be addressed. I want to thank Senators Utke, Abler, and Mann for joining me as co-authors on this bill. I also want to thank DHS staff for their ongoing work with the bill proponents on technical assistance for the bill, which, as I said, is ongoing. And I will now turn it over to our testifiers to further elaborate on the need for this bill.
Thank you. And let's see, Ms. Skelton?
Hi, my name's Ellie Skelton. I'm the Executive Director at Touchstone Mental Health and also the President of the Minnesota Providers Association of Minnesota. Touchstone Mental Health provides residential treatment, case management, supportive housing services for about 2,000 individuals in the Twin Cities metro area. Thank you for the opportunity to testify in support of this legislation. This bill contains language to address some of the regulatory requirements that are frustrating to staff. Especially the first two are about how do we build the pipeline for the mental health workforce in Minnesota. So we're really looking at ways to get individuals that have lived experience, that have had other types of experiences in their lives that maybe don't have a traditional bachelor's degree, and working towards making sure they have supervised work experience, especially with the target case management openings across the state. If we can have case management associates work for a couple years, learn, and be able to get into the target case management field. Currently, there's a very burdensome amount of mentorship required per week, and we're moving that to clinical supervision per month, and I think that will be very successful in helping people get into the field. So we're really excited to see that change and to work with DHS on that. The other things that we're looking at are around our Bill of Rights. Currently, our clients need to have 2 sets of Bill of Rights, and we also have that legislation in the 245I regulation. And so that, like the discharge, we have a whole statute in 245I around discharge. So the discharge statute that's for nursing home, that we're just taking that out and saying everything in 245I is what we follow. So just kind of, things where our staff say, this doesn't make sense. It says we're supposed to do this here, but we're also supposed to do this here. So it's just making things clear to make sure we're following good care for Minnesotans. That's all the Healthcare Bill of Rights clearing up. And then Section 6, we're just aligning some of the timeframes to make things easier for folks in terms of making sure that when people enter a residential treatment program that we're not asking them to do assessments every couple days, we're doing them all at one time and doing a thorough assessment for their treatment. I'm available to answer any questions or get into any of the nuances if you're interested in the subdivisions around the Healthcare Bill of Rights or some of the pathways into the mental health career. Happy to take those questions.
Thank you very much. And then I have a testifier who's on Zoom, Ashley Chose. If you could please state your name for the record and begin.
Yes, I am Ashley Chose. I am the CEO of Woodland Centers. So Madam Chair, members of the committee, thank you so much for the opportunity to testify today. As I said, as the CEO of Woodland Centers, we are a CCBHC serving 7 rural counties in West Central Minnesota. Our team serves thousands of individuals every year, from children to older adults, and we witness every day the challenges that Senate File 477 seeks to address. Delivering mental health care in Minnesota means navigating a very complex web of state regulations that govern these services. While we're committed to expanding our programs and meeting the needs of our communities, the unnecessary regulatory burdens make it increasingly difficult to provide integrated, holistic, accessible mental health care. Senate File 477 introduces critical reforms that will strengthen our mental health system, expand our workforce capacity, enhance service accessibility, and really streamline the mental health regulations to ensure providers like Woodland Centers can focus on what matters most, and that's the patient care. So as examples, this bill's adjustments to supervision requirements would allow us to hire and retain more qualified staff while maintaining high quality care, something that is really desperately needed in rural Minnesota. As a provider of ACT services, I strongly support the bill's modification to the ACT team lead requirements. Recruiting professionals, especially for rural ACT teams, is very challenging, and these changes would provide a much needed flexibility while maintaining the service quality that's very important. Senate File 477 represents a significant step forward in addressing barriers to mental health services. It acknowledges the realities that we're facing as providers and ensures we can continue to meet the needs of our communities with compassion, efficiency, and professionalism. I urge you to support Senate File 477 for the benefit of mental health providers and the thousands of Minnesotans that are relying on these services. Thank you so much.
Thank you very much for your testimony. Members, do you have any questions about Senate File 477? Senator Abler.
Well, thanks, and I'll be brief. The more we can streamline our operations, the better. However much money we have, it's always better to have more effective things, and this bill does that, and we need 50 more of these to slide through in a very flexible CMS, and we actually can make it. Thank you, Madam Chair.
Thank you. Any other questions or comments? I don't see any others. Senator Boldon, any other final thoughts?
Just a thank you to the committee for hearing this. This really is, as we have discussed often in this committee, we know there are mental health needs across our state. This is a way to help address that without a cost, which we know is a challenge right now. But making changes, common sense changes to streamline processes and allow the folks doing this critical work to spend more of their time doing that work instead of on paperwork and those types of things that don't bring value or care to people is the right thing to do. And so I want to thank all of the work from stakeholders and the department that has gone in over many months to get to this point, and I hope we can continue to move it forward.
Thank you, Senator Boldon. Yes, it has been a lot of careful work, and I really appreciate that there are people who are willing to work so closely to come up with ways that we can help the workforce. We have requested a fiscal note on it just to make sure that we understand that there are no costs or if they come up with some. So we will be laying Senate File 477 as amended. We'll be laying that over Thank you. And then Senate File 8, Senator Boldon.
Thank you, Madam Chair. I believe I also have an amendment for, an author's amendment for this bill.
Yes, Senator Boldon moves the A1 amendment. Members, all those in favor, please signify by saying aye.
Aye.
Any opposed? The A1 amendment is adopted. Senator Boldon.
Thank you, Madam Chair, and committee members. Minnesota is currently grappling with a mental health and substance use crisis that affects individuals across all ages and communities. As of February of 2021, 37% of adults in our state experienced symptoms of anxiety or depression. Can say with confidence, I would imagine that number would be higher today. We also know that 80% of our counties qualify as mental health professional shortage areas, and only about 25% of Minnesotans seeking mental health care receive effective treatment. Our current healthcare system has a lot of room for improvement. That is an understatement. We know that many of our services are piecemeal and not always integrated. The bill I'm presenting today stands to make a significant impact on mental health care in Minnesota, making the collaborative care model a reimbursable Medicaid benefit in our state. Collaborative care is an integrated approach to healthcare that focuses on treating common mental health conditions within primary care settings. It involves various health practitioners, including primary care physicians, behavioral health care practitioners, and psychiatric specialists, working together to treat the patient as a whole person. The goal is to improve patient outcomes, reduce costs, and empower patients and their families. Every dollar spent on collaborative care saves $6.50 in reduced healthcare costs and improved productivity. What this language does is allow specified providers to bill Medicaid using collaborative care codes, establishes a sustainable reimbursement rate, and allocates some grant money for startup and training costs. Collaborative care is not just a theoretical concept. It's a proven, evidence-based solution that is currently covered by Medicare and nearly all commercial payers, with 37 states already offering it as a Medicaid benefit. Let's make Minnesota the 38th. In closing, the collaborative care model represents a transformative step towards comprehensive mental health care. The benefits are clear: improved mental health outcomes, cost savings, and sustainable reimbursement rates that attract and retain providers. By passing this bill, we can help Minnesotans access quality mental health care and use our resources and dollars more effectively. In your package, you will see a one-pager that has support from a variety of organizations who will use and benefit their patients with this model. I do have 3 testifiers here today who can share a little bit more about the functionality of the collaborative care model and give examples of how it has improved their patients' outcomes, as well as answer more technical questions about this approach.
Thank you. Yeah, I have Dr. Tyler Winkleman and Frank Jadwin. And if whoever wants to go first, if you could please state your name for the record and begin.
Good morning. Thank you, Madam Chair, members of the committee. My name is Frank Jadwin. I'm a clinical social worker by training. I work with Hennepin Healthcare, supporting their integrated behavioral health efforts under the collaborative care model. And I'm honored to be here today to present the collaborative care model to you all, which is an innovative and effective model of care demonstrated in more than 100 randomized clinical trials to be an effective intervention across diverse diagnoses, patient populations, and treatment settings. Collaborative care model has designated billing codes that are reimbursed by Medicare, most commercial plans, and Medicaid plans in 37 states, and our hope is to make Minnesota the 38th state to recognize this service as a Medicaid benefit. The collaborative care model is a team-based approach that integrates behavioral health services, meaning mental health and substance use treatment, into primary care settings. It is designed to improve the care and outcomes for patients experiencing behavioral health conditions by fostering close communication and coordination among healthcare providers, including the primary care provider, a behavioral health clinician, and a consulting psychiatrist. It does this with the assistance of a registry tool that monitors a patient's progress. The collaborative care model differs significantly from traditional mental health services in its integration and accessibility. In traditional models, behavioral health services are often siloed from primary care, meaning that the patients must seek separate, specialized care. This can create barriers such as long wait times, stigma, and limited access to behavioral health providers, particularly in underserved areas. We know that the majority of referrals from primary care to specialty mental health and substance use treatments don't materialize, and we know that primary care providers prescribe the largest portion of mental health medications. The collaborative care model embraces this reality and offers an enhancement by constructing a multidisciplinary team working together to coordinate care. The collaborative care model embeds mental health professionals within primary care clinics. Instead of referring patients to external specialists, primary care providers collaborate directly with experts on their own team. This enables timely treatment, reduces the stigma, and allows for coordinated care for both physical and behavioral health conditions. Research shows that this approach is about twice as effective as usual care. In the model, a patient can expect more frequent but brief interactions with their behavioral health care manager. This allows them to focus on specific treatment goals with a higher level of accountability. The behavioral health care manager also meets weekly with a psychiatric consultant without the patient present to discuss treatment plans, clarify diagnostic questions, and make medication recommendations when appropriate. These recommendations are shared back to the primary care provider, who is the prescriber, supporting their practice with the time, the energy, and the expertise of these other specialists. The last component of this model is the registry. This tool tracks patients and their progress, helps inform treatment, and incorporates another proven approach, measurement-based care. It tells the care team if what they're doing with the patient is on track and effective, and if not, it prompts the conversation to adjust the care plan accordingly. This model has shown significant success in improving patient outcomes, reducing healthcare costs, and increasing the overall quality of care. Its widespread implementation can lead to better management of chronic conditions, lower rates of hospitalization, and a more coordinated and comprehensive healthcare system.
Thank you. Mr. Jadwin, please proceed. Please state your name. And if I'm getting it wrong, I'm sorry. That's the next person on my list, but please state your name for the record and begin.
Thank you, Madam Chair. Members of the committee, I'm Dr. Tyler Winkleman. I'm a primary care physician at Hennepin Healthcare, and I direct the Division of General Internal Medicine, which is one of the largest safety net practices in the state. We staff community clinics, the Hennepin County Jail, Healthcare for the Homeless, and other clinics. Over the last year and a half, we've had the opportunity to collaborate with our colleagues at DHS to implement the collaborative care model across primary care at Hennepin Healthcare through a grant from the Substance Abuse and Mental Health Services Administration. And it's now operating in 5 clinics, soon to be 6, and it is growing rapidly because of demand. We've built a variety of tools and processes to implement this program. And in our collaboration with DHS, we're very excited to hopefully share our learnings with other practices across the state to ease implementation of this model. As a provider working in the collaborative care model and as the director of a primary care division, I've really seen the positive impacts of this model firsthand. We had the opportunity to speak to Senator Utke yesterday, and he asked a very good question, which is, what are the numbers? So I spent my afternoon yesterday reviewing the numbers, and there are a variety of studies that look at the economic outcomes for this model of care. It decreases total cost of care by 13%, according to a very impressive study out of Kaiser Permanente. And there are dozens of other studies across the country that show that, in general, it reduces total cost of care by about $1,000 per year per patient. And it primarily does that by reducing emergency department visits and hospital services. Another study I found is that if this model were implemented nationally, it would save Medicaid about $15 billion. It is, in our estimates of the current rates, about half the cost of traditional mental health services. And it really does deliver care more efficiently. It keeps people with mild to moderate mental health and substance use issues in primary care, and it reserves specialty care for people with more severe cases of mental illness and substance use disorders. There's very strong randomized control trials that show that it improves patient outcomes and reduces the number of days that people are out of work because of their mental health. And I think as a primary care provider, it also really reduces burnout and increases retention in primary care practice. So I just want to ask that you support this bill and that we become the 38th state to include collaborative care as a Medicaid benefit so that this program is sustainable across Minnesota. It will improve the mental health in our state. It will strengthen the primary care workforce in both rural and urban communities. If passed, I cannot promise you that the primary care providers in your community won't want to give you a hug. Thank you.
Thank you. Next, I have, is it Kyle Darnell?
Thank you, Madam Chair,
Welcome to the
members.
Please state your name for the record please state your name for the record and proceed.
My name is Dr. Kyle Darnell. I'm a psychologist by training and currently the Executive Director for Behavioral Health for CentraCare, which is a rural healthcare system located north and west of the Twin Cities Metro. I wanted to highlight briefly the existing gaps in supply and demand and how the collaborative care model will help impact the future of care delivery for Greater Minnesota. So I've provided some handouts that illustrate the statewide current psychiatric needs. According to the Health Resources and Services Administration, Minnesota currently has 62% of what we need for adult psychiatrists and 63% of what we need for child and adolescent psychiatrists. By 2037, we anticipate our adult psychiatric workforce to decrease, while the demand is expected to increase, leaving us at 40% of what we will need. Although we expect a moderate increase in child and adolescent psychiatrists, the demand will outpace, and we anticipate we will be at 56% adequacy by 2037. These are statewide projections. We know that our providers are not evenly distributed across the state and our regions, and that 80% of our counties are designated health provider shortage areas for mental health. My final handout is based on the number of licensed providers by zip code and population to provider ratios. When it comes to psychiatry, 3 of our 6 regions currently have population to provider ratios that are twice as bad as the statewide total. Specifically, for the entire state, we have approximately 1 psychiatrist for every 8,000 patients. But in the central region, where my office is located, we have approximately 1 psychiatrist for every 21,000 patients, with the northwest and southwest regions closely following, nearly tying for second to last place. Without successful recruitment of a shrinking workforce, I anticipate CentraCare will have 50% decrease in full-time equivalencies of psychiatrists in the next 5 to 7 years. Even though we are collaborating with the University of Minnesota to build a new medical school and to expand the psychiatric residency program, we will not be able to train enough new psychiatrists to close the gap on the current or the anticipated needs. For rural healthcare, the collaborative care model is not just innovation, it's not just improvement, it's not just about meeting the best contemporary standards of care, it's a necessity. It is a lifeline. It is the way we will deliver psychiatric care to rural Minnesota in the future. Thank you.
Thank you very much for the testimony. Members, do you have any questions about the bill? Senator Abler.
Well, just really brief, but I appreciate the 6.5 to 1 or the 13% reduction and all that. And Senator Wiklund and others and to the department, the only way we get out of this budget thing is by looking at a comprehensive look at some of these proposals. So I don't know what your target's going to be, but if you don't have $1 million for these grants, this bill's not going to go forward, and we're going to spend all the money that we wouldn't have spent and not serve people. So the process that we do is going to be in place now, but I'm going to predict come June 10th or June 20th, that'll look at the kind of savings this could happen, where we compress the fiscal note now and then what's going to happen in November, and like look at them creatively. We did it in 2011. It's going to have to happen now, otherwise we're going to be in a world of hurt. So that's, I'm telling everybody that just to the department and even to the governor. So we'll have to, that's the way out of this, Madam Chair, in a way that we all could support something. Thank you.
Thank you. Any other questions? Senator Boldon, you know, it does seem like a very promising model that you've already seen results through implementation, saving money and getting people to the right level of care at the right time. It has a lot of advantages. We have requested a fiscal note so that we can better understand what the cost to implement it on a more statewide basis would be. Any final comments?
Thank you, Madam Chair. Thank you, members, for the discussion. I think your summary was exactly right. This is a proven model that is working, that it allows greater access to what mental health care and substance use care, which we know is greatly needed across our state, gets people to the right care at the right time, allows for that integrated, connected, collaborative way to treat the whole person, and also will improve our workforce issues. So appreciate the committee's consideration.
Thank you. And with that, Senate File 8, as amended, will be laid over. And now we'll move to Senator Mann, excuse me, Senator Mann, 1561. Senator Mann, I think you have an author's amendment.
Madam Chair.
Senator Abler.
I just have a question, just thematically. It takes a lot of min choices. I think simplification. Could I just ask the author why she's abandoning that for now? And is it kind of, I think there's some kind of cool stuff there. So.
Senator Mann.
Madam Chair, yes, Senator. So we took out min choices. We wanted that piece to move on its own. That's all.
Perfect.
Yeah.
Thank you.
I'd also make some retroactive funding date changes, clarify some eligibility language. That's it.
Okay. Senator Mann moves the A2 amendment. All those in favor, please signify by saying aye.
Aye.
Aye. Any opposed? The A2 amendment is adopted. Senator Mann.
Thank you, Madam Chair. Members, we have a children's mental health crisis in Minnesota, with children not having the proper supports and proper levels of care. So what happens is that children are dropped off in emergency rooms across the state, and that is where they stay until a proper care setting can be found. They are also sitting in counties and in detention settings. And while we try to find the proper setting for them, they wait. And this can take days and weeks and months, and in some rare cases, it can take years. In my little rural hospital several months ago, we had a little girl stay with us for a couple of weeks. We don't even admit children to our hospital. And so the ER doctors would take turns with the pediatric clinicians, seeing her every day and taking a little bit of time to play games with her. This is not what was best for her, and it certainly was not what she needed. But as a state, for weeks, this is all we had to offer her. In 2023, children across the state spent 12,000 avoidable days or boarding in hospitals waiting for the right level of care. On any given day in 2024, almost 20% of children in detention settings were boarding. We are essentially jailing children instead of getting them mental health treatment. So that is why this bill is in front of you today. It elevates and prioritizes services that we know work for children and families. Most of the things in this bill are scalable, so I look forward to working with everyone here to figure out what we can accomplish given our budget constraints. With that, Madam Chair, I will turn it over to Kristen Anderson to walk through the bill.
Thank you. Please state your name for the record and begin your testimony.
Madam Chair, members of the committee, my name is Kirsten Anderson. I'm the Executive Director of Aspire Minnesota and here solely to walk through the bill with you this morning. So sections 1, 4, 6, and 7 address certified family peer specialists, including clarifying the use of existing grant funding, expanding eligibility to serve as a certified specialist, and expanding eligibility and access to training requirements. Sections 2 and 25 establish a youth care professional training program to deliver required training for staff in children's residential mental health, day treatment, and juvenile detention settings with an online training and record system that would allow staff to transition employees without having to repeat training. Sections 3 and 21 builds capacity of high fidelity wraparound, a service that's designed to support complex children and families with a team and strengths-based approach. Language will support counties to partner with community providers and apply for the specialized Medicaid reimbursement for the service. Sections 5 and 26 define and continue funding for the youth care transition team model that has proven highly effective in transitioning children from hospital boarding and from PRTF care to youth-focused community-based service designs. Teams have a mental health professional, skills, and family peer staff and available for 90 days following transition to support the child and family. Section 16 and 23 establish a working group to examine how Minnesota can update and expand our psychiatric residential treatment facility benefit to best meet the needs of children and families, considering licensing, rate methodology, encouraging PRTF care in expanded settings within potential growth opportunities. Section 17 and 22 address boarding decompression, which is a national best practice that builds solutions to the crisis of children boarding by funding child-specific solutions to make it possible for them to access community-based care. This pilot would be held within the Mental Health Collaboration Hub, where experts meet weekly to review clinical cases of children boarding and suggest ways we can get to yes or transition children to community care. The hub would advise and propose innovative solutions and track outcomes to inform future solutions for children boarding. Section 18 fixes the, quote, third path funding for a child to access residential mental health treatment without entering the child welfare system. And this solution will require the Behavioral Health Fund to reimburse the provider at the published room and board rate of a Title IV per diem. Section 19 increases reimbursement for in-home care that is highly effective and low cost, increasing access to care that is offered within the home. Section 24 invests in targeted recruitment for children's respite providers intended from the wider mental health provider community. And that's the bill.
Thank you. And I have three other testifiers. Jennifer Gustafson. Welcome to the committee, and please state your name for the record and begin.
Yes, good morning, Madam Chair, members of the committee. I'm Jennifer Gustafson, the clinical supervisor at the Dakota County Juvenile Services Center. I'm here today representing the Minnesota Juvenile Detention Association, or MNJDA. MNJDA facilities have become a safety net in the mental health continuum of care. Children with significant mental health conditions are boarding in juvenile correctional facilities. Over the past 5 years, there's been a significant increase in the number of children boarding in detention facilities. In 2024, a survey of MNJDA facilities showed that on June 1st, 20% of the youth in our facilities were boarding because of their mental illness. As clinical supervisor, I can share that we are woefully under-resourced to meet the needs of children who are boarding in detention. Our youth caring professionals do their very best to provide trauma-informed responses and to create accommodating and therapeutic spaces. And truthfully, the children in our care require far more than detention is designed to provide. We have children as young as 10 years old boarding in detention. The structure of a detention facility, from physical space to daily routine, can be challenging. There are limits to what can be done to support the individual mental health needs of a child. As an example, a child who's 12 years old who's been discharged from a mental health setting now finds themselves in a correctional facility with youth who are much older and who have different challenges. They are embedded into a structure that provides safety but does not support their unique individual needs, such as intensive individual and family therapy, psychiatric services, occupational therapy, and other services. Boarding can be discouraging for children and create hopelessness and frustration. We know there are solutions that can help children transition from boarding to community and treatment settings. One solution that supports youth transitioning from corrections is high-fidelity wraparound. High-fidelity wraparound is a highly effective service that supports transitions and can help prevent youth from needing more acute care by ensuring the right services are in place. High-fidelity wraparound is designed to support families to establish long-term solutions to meet their needs, including natural community relationships and supports. One provider shared 24 months after completing WRAP, 92% of youth remained in community, not requiring a higher level of care. Senate File 1561 will build capacity for this specialized service to grow the model across the state. Children should not be boarding in Minnesota. We know detention is not an appropriate treatment setting or safety net for our kids. We support solutions to children boarding in Senate File 1561 and know that together we can do better to support our children. Thank you.
Thank you very much. Now I have Dr. Margot Zarin-Pass, and also I have Todd Archibald. Welcome to the committee, and please state your name for the record and begin.
Thank you, Chair Wiklund and committee members. I'm Margot Zarin-Pass, and I'm a pediatrician at Children's Minnesota. I appreciate you all having me here today to share my experience caring as a doctor for the children who are boarding in our hospital because they can't access appropriate mental health services. And my goal today is to tell you all more about the patients and families who find themselves in this horrible situation. In many cases, the children I'm taking care of in the hospital are brought there by their family who aren't getting the support they need to care for the child they have. The emergency department is their last resort. We never turn kids away. Commonly, the child in question is having behavioral outbursts or aggressive episodes. And they may have experienced extensive childhood trauma or abuse. They may have neurodevelopmental differences like autism. For whatever reason, they lack the coping skills they need to deal with the stress they have. And their families are at a breaking point. And no matter what the situation is, hospitals are not what these kids and families need, much like the patient you were taking care of, Dr. Mann. I want to be super clear that these are not hopeless cases. These kids are beautiful, they're smart, they're curious, they have enormous potential. And with the support that they deserve, that potential could be realized. If I had a magic wand, I would give these children and their families access to intensive family therapy, skill building, respite care, resources like the youth care transition teams, so that they could move from the hospital to the right treatment setting and make sure that they're getting ongoing support. I would make sure that resources could move efficiently and be targeted to that child and family's specific needs. My colleagues and I are on the front lines of this mental health crisis, and we see where the current system is failing children. The bill before you and other bills today finally move the needle on this issue and ensure that kids and families could get the care they deserve. So thank you, Senator Mann, for your leadership on this bill. Thank you, committee members, for your time.
Thank you. And please state your name for the record and begin.
My name is Todd Archbold. I'm a social worker and the CEO of Prairie Care. Chair Wiklund and members of the committee, thank you so much for the opportunity to speak today on behalf of this bill to address the urgent needs of children with complex needs who are stuck boarding in hospitals, detentions, and in counties. As highlighted in the recent report by the Center for the Advanced Studies in Child Welfare at the University of Minnesota, children with mental health needs are often left in hospital emergency departments, not for treatment, but simply to be kept safe. This is not just a failure of our system, it is a failure of our humanity. These children, who are vibrant members of our community, are being deprived of the treatment they desperately need. They're not just statistics. They're individuals with dreams and aspirations. They're artists, athletes, students, and friends. They deserve better. The report emphasizes that many of these children are stuck in a cycle of boarding due to the lack of available and appropriate care options. As one parent poignantly noted, "When my husband had cancer, the whole family had cancer. It wasn't just him." This sentiment rings true for our children. When one child suffers, the entire family bears the burden. We must recognize that mental health care is not just about the individual, it is about the family system as a whole. This bill seeks to expand access to community-based services, which is crucial. The report indicates that intensive community-based services can prevent the need for higher level of placement. Investing in these services is not just a moral imperative, it is a practical solution that can save money for all of us in the long run. When we provide the right support early on, we can prevent the escalation of crises that lead to emergency room boarding. Moreover, the report underscores the importance of collaboration among communities and providers. The Mental Health Collaboration Hub was established to bring local clinical leaders and hospitals together to identify possible care pathways for children who are boarding. This effort, driven by the goodwill and a commitment to kids, has shown us that when we work together, we can create a more effective and compassionate system. As one expert in the hub stated, it's people coming together to the table to listen to each other. We need to foster this spirit of collaboration to ensure every child receives the care they need when they need it. As one recent example, a bright and insightful teenage girl went to the emergency room in crisis. She had faced unimaginable challenges, living with autism, depression, and PTSD, having experienced the horrors of sex trafficking. She had been in and out of treatment centers, and her misbehavior resulted in continual setbacks. These misbehaviors, by the way, they're a symptom of her illness, the voice of her despair. Hospital staff shared her case with the Mental Health Collaboration Hub, which opened the door to a network of dedicated professionals committed to finding the right treatment for her. After 172 days of boarding, this child was finally offered a chance at a fresh start in a local intensive treatment setting where she received the services she desperately needed. This bill leverages the expertise of those participating in the fund to implement a boarding decompression pilot to fund individualized solutions for children to transition to community-based care from boarding and track those outcomes to apply lessons learned in ongoing solutions. Thank you, Senator Mann, for this important legislation, and to this committee for your support. I believe together we are on track for a brighter future for Minnesota's children. Thank you.
Thank you. Members, any questions about the bill or comments? Senator Curran.
Thank you, Madam Chair. Senator Mann, was the initial statement, was it 12,000 overnights or 12,000 days for psychiatric care? Was that the, and those are the unbillable days in a hospital? That doesn't include all of the others, because that, I think it highlights one huge burden on the hospitals where we're overnighting children or minors, in addition to, you know, a whole host of child protective services or our group homes where they also come in and can be dropped off for months at a time with no ability to provide for them. And I think even in the Mayo, some are there 600 days, and those are non-billable. And so that's a burden, right? Besides not providing the service, it's a huge burden. I like the idea, right? And hopefully it goes far enough that we have a task force that, because it's always a combination of Department of Human Services in many cases, and maybe it's a combination of some of these, and local human services. So I would hope that it could tackle at least a component of that, and we can figure out a way to do the others, because it would be great to see. I've never seen the number, but you've got just psychiatric, but all of the others, every time you go in there, I now ask that question: how many billable days, or how many of those scenarios come through? They never delineated from psychiatric, but it was really kind of just abandonment of 2 or 3 minors, and you know, it could literally be there for 3 or 4 months with absolutely, and in a room that has no facilities. It's really the psychiatric room, right? The mental health room with not even restroom facilities in our community. So I hope we find a way to do this. I hope we find a way to pay for this. But I'd also like to work with you if we can figure out an inventory. What is that number kind of statewide for all of those other all-cause? Because there's a lot of minors dropped off in those facilities, so, and group homes as well. They end up sitting there for weeks and months. So, thank you.
Senator Mann, did you have any? Okay. Any other?
No.
Okay. Any other questions or comments? Thank you, Senator Mann, for bringing this forward. I had an opportunity to visit the Dakota County, the Juvenile Service Center last fall, and it was sobering to think about kids having to stay in these facilities that are not designed for that kind of care that they need, and not having access to the right treatment. And it's really, it's an emergency, and we do need to do whatever we can about it. I think that your bill has a lot of really good ideas in it. I hope that we can get a fiscal note back and take a look at them. I think underlying rates are a big part of the problem too, but thank you for bringing it forward. Any other final thoughts? Senate File 1561 as amended will be laid over. And lastly, Senator Mann, you have Senate File 928.
Thank you, Madam Chair. I do have an A1 author's amendment, which is a technical definition change.
Senator Mann moves the A1 amendment. All those in favor, please signify by saying aye.
Aye.
Any opposed? The amendment is adopted. Senator Mann.
Thank you, Madam Chair. So 928 is a bill that takes priorities from the wider mental health legislative network to do several things. It provides support for children in school-based mental health services. It improves safety for children's non-emergency medical transportation, or NEMT. It establishes aftercare supports for children and families during transitions from intensive residential mental health care to a home, which is a critical time period for these families. All these are really important pieces to sustaining effective services and resolving, or part of resolving Minnesota's children's mental health crisis. So Section 1 will allow for school-linked behavioral health grants to support parents to access mental health services if this is needed to meet the treatment needs of the child. Section 2 modifies NEMT to require that a child receive door-to-door services and increases the reimbursement rates for these specially trained drivers. Section 4 establishes aftercare services, and Section 5 appropriates funding for the school-linked behavioral health grants to address the $5 million cliff in funding approaching in 2027. With that, Madam Chair, we have testifiers.
Thank you. And I have Shannon Brown and Lisa Zhang. Thank you. Please go ahead, state your name for the record and begin.
My name is Shannon Brown, and I'm the CEO at Fernbrook Family Center. Thank you again for the opportunity to testify in support of Senate File 928. Senate File 928 will improve the mental health services for kids and families in Minnesota by sustaining current school-based mental health services, increasing safety for children who need non-emergency medical transportation, or NEMT, to access care, and providing aftercare for children in a transition home following intensive residential care. Our school-based mental health services have a funding cliff in 2027 that would reduce funding to grantees of these services and leave some students without needed mental health care. Sustaining the current level of school-linked mental health funding is critical to continue serving students using a model that we know works. Senate File 928 proposes language that would allow providers to initiate support for caregivers when needed to support a student's treatment goals. It is all too common for us to see caregivers struggling to support the mental health needs of their children because of their own anxiety, depression, post-traumatic stress disorder, or other mental health concerns. What we have seen work time and again is that when we provide mental health services to stabilize the caregiver, they're able to support the mental health needs of their children, and that's when we see progress happen. Senate File 928 would also create enhanced safety and access for children who need non-emergency medical transportation to attend day treatment or other regular mental health services. NEMT was not designed for children, and providers are not trained on child needs. The result has included countless unsafe experiences that this proposal can help to avoid. By requiring children be served door to door, we will have fewer children dropped off without confirming they're in the care of a safe adult. This proposal increases reimbursements for drivers with a Type 3 school bus certification that trains drivers on responding to the unique needs of children, with the goal of incentivizing the use of this excellent training so drivers are prepared to serve children, resulting in improved safety and access to NEMT for children with mental health and all healthcare needs. Finally, establishing aftercare is critical for a child to maintain treatment gains following inpatient or residential care. Children's Therapeutic Supports and Services, or CTSS providers, can engage with children and families with building skills, assuring positive transitions with school, family, and community so the child and family have a sense of support and confidence as the child reestablishes daily activities at home. This legislation would allow us to initiate these critical aftercare services when children are discharging from hospital, detention, or residential treatment. Aftercare services are effective and currently available for adults, and this proposal makes the same aftercare available to children and families. When we're able to prevent unneeded stress and confusion for families by simply assuring a smooth transition, we know we can reduce recidivism and ensure successful integration into the community. Thank you for your support.
Thank you. Ms. Zhang, please state your name for the record and begin.
My name is Lisa Zhang, Madam Chair, members of the committee. I'm a licensed marriage and family therapist and the Senior Director of Clinical Services for Changing School-Linked Mental Health Program. Thank you for this opportunity this morning. For 20 years, Changing has provided school-linked services. We are in 35 schools across St. Paul, Minneapolis, Brooklyn Center, and Osseo School District, serving 607 students in the 23-24 school year, delivering over 18,000 hours of care. School-linked mental health gives consistent and accessible services, removing transportation and economic barriers. Minnesota's goal is to have school-linked mental health available to every child statewide. School-linked mental health is early intervention, preventing children's mental illness from escalating into crises that require inpatient care and cause youth boarding issues. The model includes multiple partnerships between the state, counties, community partners, and school districts, a village of helpers, and a model built over the last 20 years to support kids and families. However, the future of school-linked mental health is at risk. We're sitting at a $5 million cliff. Without continued investment, we risk losing the progress Minnesota has made and the children who depend on these services. Here's a story of resilience and healing, a single father of 8 struggling after losing his partner. His children were in and out of foster care, missing school. The kindergartner was running out of class, experiencing mental health crises. Through school-linked mental health, they received the support they needed. Today, that kindergartner is on track to graduate high school. This outcome was possible because Minnesota invested in children's mental health. Without it, foster care and academic failure would be this family's legacy. Investing in children's mental health yields long-term benefits, not only for the individuals directly affected, but also for our communities. This bill is a lifeline for families like the one I just shared with you. It's about breaking cycles, building resilience, and giving children the chance to succeed. Let's continue to build on the foundation Minnesota has laid, investing in school-linked mental health to create brighter futures. Thank you, Madam Chair and members of the committee.
Thank you very much. Members, do you have any questions? No? 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 Thank you, Senator Mann. Another bill that has some really key components that are really, we would like to continue funding, and we will get a fiscal note and take it into consideration. Do you have any final comments? No? All right, thank you. Senate File 928, as amended, is laid over. And we have reached the end of our agenda, and we are adjourned.